Greeting to the Center for Translational and Experimental Cardiology. This is Shihab Anwar, postdoctoral fellow at Echocardiography Lab, led by Professor Felix Tanner at the University Heart Center Zurich. And I would like to thank you for your kind invitation and for your interest to know more about the strain analysis, especially regarding that of the atrium. I'd like to start with a definition that starts from the Old Latin language, where an atrium meant an open-roofed entrance hall or a central court in an ancient Roman house. And this is depicted in the anatomy of the two atria. As you can see in the anatomic cadaver, the left atrium receives the 4 pulmonary veins from the pulmonary circulation, while the right one receives the superior and inferior caval veins from the systemic circulation. And as the atrium keeps the blood reserved until the ventricle finishes the contraction or systole, then when the ventricle starts to relax, an early diastole phase starts and the ventricular pressure drop. Here, the atrial elastic compliance acts as a conduit to allow the blood to flow across the gradient. And finally, the atrial muscle fiber contract and pump in order to ensure the optimum necessary evacuation of all its reserve that was supplied inside the atrial cavity from the systemic or pulmonary circulation to the ventricle, and maintain the cardiac output during the cardiac cycle, one after the other, in respect to the systemic circulatory condition. The atrium is actually a pretty dynamic chamber. Therefore, the measurement of its dimension is not enough to describe its different function, namely reservoir, conduit, and pump function as described earlier. And there comes the importance of the strain analysis using speckle tracking echocardiography, where the software allows us to process the cine loops in a way to identify the speckle across the contour of the chamber we analyze. In this cine loop, this is the right ventricle, the right atrium, and the tricuspid valve in between, as seen by an apical view using echocardiography. And then the software starts to depict the speckle across the region of interest we plan to measure, which is here, for example, the right atrium, and then provides an index between the difference in the spatial location of the speckles between the end diastole as well as the end systole time points, so that it provides you an indicator of the deformation of the ventricle or the atrium according to what you aim to study. And this happens in each frame of the cine loop, so it gives you a whole curve that depicts the whole cardiac cycle. Another very important aspect that the strain analysis is not confined only to one direction, longitudinal, as we mentioned earlier, but it can also include many different components, and it can calculate across longitudinal, radial or transverse, or circumferential, which is around the circumference of the chamber we are measuring. However, the current focus is mainly on the longitudinal strain, and more light is being shed on the other components in current literature, as well as how robust it can be in 3D echocardiography, which will come later, as one cine loop can represent all the required sections to analyze the components in different directions, while the two-dimensional echocardiography and the strain analysis there requires multiple views to represent different sections and depicts the change in the form, which is the strain analysis. As soon as the strain analysis software finishes the processing of the cine loop, it provides you with a curve representing the average strain of all the speckles that are moving across the different segments of the heart based on your tracing, and they are averaged to provide you with a global curve to present the global strain or deformation of the targeted chamber. In this curve, it depicts the global strain curves of the right atrium on top, represented by the dashed lines, and the right ventricle in bottom, represented by the bottom lines. And as you can see, as soon as the ventricle is stimulated by the R wave, it starts to contract, and hence the value of the strain becomes negative because it starts to shrink or get smaller and during the systole. And by the time at the end of the systole, it reaches its peak or nadir value, at the lowest point, depicting the maximum negative deformations that happened of contraction due to the contraction. And then, as soon as the contraction ends, the heart starts to relax, and then you find it the right ventricle strain curves getting back to its baseline again around the zero line. On the other side, reciprocally and harmoniously in the same time, the right atrium, it is receiving the blood to reserve it, waiting for the ventricle to finish the systole. By the time the ventricle finishes the systole, the atrium as well is at its peak value, which is the reservoir strain, and then as soon as the ventricle starts to relax during the early diastole, the atrium starts to conduit the blood slowly, and then at one point when the P wave happens and the atrium is muscle fiber are excited, it contracts, leading to the last phase, which is the pump phase. All of that happen as an excellent harmonious scheme play, resulting in an homeostatic circulation that maintains the cardiac output in the human body. Speaking of atrial strain and team play, our echocardiography, arrhythmology, and interventional cardiology teams, especially those specialized in the field of arrhythmogenic right ventricular cardiomyopathy, atrial fibrillation, pulmonary vein isolation, aortic stenosis, and transcatheter aortic valve implantation, they lead to this publication on the topic. And therefore, as a part of these amazing teams, I would like to thank everyone among the authors of these manuscripts for their dedication and interest to explore new frontiers in the echocardiography and shed the light on the role of the atrial function, especially in prediction of outcomes in different cardiovascular conditions. Was in the European Heart Journal Cardiovascular Imaging, where we have investigated right atrial strain in arrhythmogenic right ventricular cardiomyopathy. And in this cardiomyopathy, the myocardium is characterized by progressive fibrofatty infiltration and usually is associated with adverse cardiovascular outcome in these patients. And in this study, we aim to examine the right atrial deformation in ARVC and understand its association with cardiovascular outcome of atrial arrhythmia or a combined endpoint of atrial ventricular arrhythmias, cardiovascular mortality, and heart transplant. Right atrial strain was determined in 50 patients with definite ARVC, compared with a matched control group of 50 healthy individuals. And they were analyzed for outcome association over a median follow-up of 5 years, during which 30 patients experienced one or more cardiovascular events and 11 experienced atrial arrhythmia. In the initial analysis, it showed that the ARVC patients display impaired right atrial strain even when the right atrial volume is normal. As you can see, the majority of the patients with definite ARVC had exhibited normal dimensions of the right atrium. Meanwhile, the strain analysis showed that the right atrial reservoir strain and pump strain were significantly impaired in the patients who had definite ARVC in comparison to the control group. The reservoir strain was associated with an increased risk of atrial arrhythmia as well as cardiovascular events, and the right atrial pump strain predicted cardiovascular events as well. Reservoir strain of the right atrium improved the fitness of the bivariable models for the association of the right ventricular fractional area change as well as the right ventricular global ventricular strain with cardiovascular events. And this extends the findings of how the right atrial reservoir strain improved the association of the right atrial volume as well as various dimensional and functional right ventricular parameters, including the right ventricular global ventricular strain itself with the cardiovascular outcome. Therefore, the measurement of both and the assessment of both the right atrial and right ventricular strain might be considered as a part of a comprehensive echocardiographic assessment in patients with arrhythmogenic right ventricular cardiomyopathy. The second study we are presenting today It's about the association of different strain parameters that are provided from the two-dimensional as well as the three-dimensional strain analysis to describe the left atrial strain. And this was associated and compared to the low voltage map area depicted from the voltage mapping. And we explored the association with recurrence of atrial fibrillation after AF ablation, after pulmonary vein isolation. Here, there is an important point that we would like to show, that this is an example of a 3D strain where a one volume acquisition allow you to trace the atrium in different aspects and therefore provide you multiple components and the strain curve in different directions to depict the different forms of deformation happening in the chamber you are analyzing. Regarding the methods and results of this study, the 3D longitudinal atrial strain and the two-dimensional as well was measured, as well as the low voltage map was calculated in 93 consecutive patients who underwent pulmonary vein isolation, and we analyzed the association of these parameters in association with the recurrence of atrial fibrillation after the blanking period has passed. And unfortunately, 12 patients experienced atrial fibrillation after that period. In this study, the three-dimensional reservoir and pump strain of the left atrium was associated with the recurrence of atrial fibrillation after the blanking period after undergoing the pulmonary vein isolation. And the association of the 3D left atrial strain was independent of relevant clinical and echocardiographic parameters and improved their predictive value. Hence, they may be applied for the outcome prediction in patients undergoing PVI to ablate the atrial fibrillation. Last and not least, in this study, our latest publication on the topic, we aimed at investigating the left atrial deformation by left atrial reservoir and pump strain and its implication for long-term survival in patients with severe aortic stenosis undergoing transcatheter aortic valve implantation, where the speckle tracking echocardiography was performed in 198 patients with severe aortic stenosis who underwent TAVI at University Heart Center Zurich. And the association of the strain parameters with the cardiovascular mortality was determined, and the pump strain was impaired in patients dying during the long-term follow-up after TAVI, as shown by significant differences between the survivors and non-survivors. This study found that the left atrial pump strain was independently associated with long-term mortality, and the more impaired it is, the more the patient is at risk of mortality after undergoing TAVI. And this yielded a potential incremental value for survival prediction after the procedure. And left atrial pump strain seems to be useful for risk stratification in those group of patients who had severe aortic stenosis and underwent TAVI, and this can assist later in the timely decision of valve replacement. Conclude. The atrium plays a complex role, essential to fine-tune and maintain a homeostatic circulation, with sufficient functional role to reserve the blood, conduit the blood, and pump it to the ventricle. And the mechanics of the atrium and its study throughout the cardiac cycle and the functional phases as described before became feasible with several solutions that are available to measure the atrial strain, and that goes in hand with the robust utility and advances in echocardiography as well as in different other modality of imaging. And these show promising results to shed more light on the forgotten chamber and provide answers to advanced topics like prognostication or early detection of cardiac dysfunction, not only the systolic one, but provide more info on the diastolic dysfunction in ventricles to make it a new team member to help our understanding of cardiovascular physiology and pathophysiology. Therefore, on behalf of our echocardiography team and the esteemed co-authors of these manuscripts, we thank you again for your attendance and interest.